conference will now be recorded.
So, the MRCOG Part 3. As we all know, MRCOG Part 3 is an exam that is slightly different from what we usually have gone through. That is MRCOG Part 1 and Part 2, wherein we need to answer questions, SBAs, EMQs, etc., etc., wherein we need to be thorough with theory. As far as MRCOG Part 3 is concerned, it is an exam that assesses how you connect with your patient, how you communicate with your patient, how safe are you, and it also assesses your knowledge. So all of these domains are assessed as far as MRCOG Part 3 is concerned. So basically, this is the final component of the MRCOG series of exams. It is kind of an OSCE type of a exam. And as we discussed, it assesses knowledge, skills, attitudes, and competencies. It is the passing of the MRCOG Part 3 leads to the award of MRCOG, as you all are aware. So what does the exam consist of? There are 14 tasks, all right? 14 tasks for MRCOG Part 3 exam, and it would be a circuit. In the on-site exam, you would have a circuit of 14 cubicles, and the candidates would be going from one cubicle to the other to answer 14 such tasks. There would be 12 minutes per task. 2 minutes would be your reading time and 10 minutes for you to do the task. So please adhere to the time limits. Whenever you practice, see that you put a timer and you practice while you are practicing. That's very important. So you have 14 tasks in 14 cubicles, and you have 2 minutes reading time and 10 minutes for you to do the task. Now, the various domains that are assessed. There are patient safety, communication with patient and relatives, communication with colleague, information gathering, applied clinical knowledge. Now, a typical task will have 4 domains or sometimes 3 domains. All 5 domains are not usually assessed in a task. So it is usually information gathering. Patient safety, applied clinical knowledge is something that is there in all the tasks. Communication with patient and relatives depends on whether it is a simulated patient task. Communication with colleagues depends on whether it is a discussion with the colleagues. All right, so as you know, it is something like this in the picture. There is a candidate who is addressing the patient's concern, and the examiner is watching you as you are doing the task. That is how the exam goes. So what are the types of tasks you have? You have the role player scenarios, which is simulated patient task, wherein there is a role player who is playing the role of the patient, and you are the candidate, and there is an examiner who is sitting right there, who is assessing you as you would be talking to the role player for straight 10 minutes. There are structured discussions, which are viva kind of scenarios, wherein a situation is provided to you and you are questioned on that situation. That is a single examiner. How do you know? And it is a common mistake to confuse if this is a structured discussion or is an SPT. SPT is a simulated patient task. Because we practice so many simulated patient tasks in the exam, it is again common to mistake that if it is an SD, that is a structured discussion, we may think that it is an SPT and start talking as though you're talking to a patient. So that should not happen. How do you know that? If it's an SD, if you have not read the task, for instance, you would know that for sure because there would be just one person sitting in the cubicle, and that's your examiner in a structured discussion. All right. While in a simulated patient task, you will have your patient sitting there along with an examiner, maybe a single examiner, or sometimes there are lay examiners as well. So one or two examiners would be there in an SPT. In an SD, it's just one examiner. So you know that it is an SD, and this confusion, whether it is an SD or an SPT, should not happen in the exam. All right. Now, Sometimes there are linked tasks, but that this is not quite common nowadays. A lot of circuits in the recent past have not had any linked task. Linked task is one particular task. Say task number 2 is about an ectopic pregnancy. Then task number 3 would be a follow-up on the same task, task number 2, and they would discuss the clinical governance measures on, say, ectopic pregnancy missed, for example. So these are linked tasks when two tasks are about the same topic, or it is a follow up on the same topic. Okay, so but again, this is not quite common. It's not been asked in the past few exams. So how do you go about this? You need to have somebody to practice with on a daily basis, every single day. If you're preparing for the exam, you're preparing for May 2026 exam, you need to practice. In the initial phase, try practicing the tasks in, say, bits and pieces, like, say, history taking. I'm going to cover history taking of maternal medicine, history taking of urogynecology today. So just do the history taking, and you should be able to finish your history within 3.5 to 4 minutes. That is how you should train yourselves to finish your history. It should not go beyond, say, 4.5 minutes. 5 minutes is too much of time spent on history. Yes, there would be a certain task where the history is long, but again, you need to be quick and to the point, and you need to finish your applied clinical knowledge and patient safety. You need to address those points as well in the task. So it's important that you keep your history limited. It is important to ask yourself whether a particular point that you ask in history is going to change in any way the management. All right. So if it is not, then it is not a relevant point. Okay. Or if it is going to tell you anything about the background of the patient, then yes. But otherwise, it is not a relevant point. All right. For instance, asking about, say, history of sexual history in a patient who's in labor, it's completely irrelevant. Okay. For that instance, a patient is in advanced labor and you are asking the patient, do you drink alcohol? Again, irrelevant. So your history should be to the point. Okay. It has to cover all those points that are necessary for you to plan her management. Do not ask things that are unnecessary. History taking is an art. It is not a tick box exercise. Please remember that. But if you say the points that is mentioned in the examiner's answer key, you would get your full score on information gathering. I think I got disconnected for a bit. All right. So your communication, how you put across to the patient is important. We will touch upon each of these parts individually when we come to modules today's session. So your safety and your reasoning. So like reasoning is basically try to understand that for a patient, a situation is given to you. Say, for example, a frail elderly woman is there. She's having a lump coming out from the vagina and she is asking for a cure. Okay. So for such a patient, normally if there is something like wall prolapse, for example, you would talk a lot about abdominal sacrocolpopexy and your sacrospinous fixation, depending on what suits her. But these options may not be ideal for her. She may be having comorbidities. So you need to take her situation into account. You may have to consider something like colpoclysis for her. So this depends on her individual situation, and that is the reasoning that you are expected to have in the Part 3 exam. You cannot, for fibroid management, you cannot just say expectant management, medical management, surgical management, blah, blah, blah. No, you need to say those things that would suit her situation. All right. And that would help her. Say, for example, she's a case of infertility. All right. Here, you cannot be talking a lot about just medical therapy, because how long are you going to give her medical therapy? If she wants to conceive, you probably need to get the leiomyoma out. So this is something that you need to take into account when you are dealing with your tasks. All right. Professionalism, because you need to, your demeanor has to exude professionalism. You need to be talking in a manner that comes across as, you should be polite. You should take into account the patient situation. You need to address the patient's reactions, acknowledge her attitude. Okay, so all this is important. At the same time, you should keep calm. Okay, that's important. So we have two exams in May and November, biannual exams. What is required? We all know you need to pass MRCOG Part 2 and you need to have your assessment of training approved by the college. So on the exam day, your conduct has to be professional. Please adhere to time. Okay, and remember, you will not have an immediate feedback on the day of exam. So don't get confused. You will have your score given to you directly. None of the examiners are going to be talking to you even. All right, so remember that. Okay, so what are the tips for the exam? The most important, you need to understand that your marking is based on domains. All right, so if you keep on taking history and you keep on thinking that, okay, for this particular patient, I will offer a Mirena, okay, and you keep on talking about Mirena, you tell her about side effects of Mirena, LNG-IOS, you tell her how it is going to be introduced, etc., etc. And then suddenly you see something like, say, she's known to have a uterine anomaly. And then you realize, oh, the Mirena was not an option for her. Okay, so you have lost on safety, you have lost on applied clinical knowledge because you haven't said the points that were actually supposed to be mentioned to her. All right, so you need to understand that you have to cover a few points in information gathering. You have to think in this scenario, in this situation, what would suit this particular patient. So you need to have an outline of plan for her, which is your applied clinical knowledge. Your outline of plan should be based on should be done in such a manner that you keep safety as your priority. Okay, your safety should be your priority. All right, so you cannot be saying that, okay, you are having a fibroid uterus and you want to conceive. I will schedule a surgery for you for myomectomy straight away. Okay, check if she's having heavy bleeding. If she's having heavy bleeding, check if she's having anemia. You need to correct her anemia before you post her for a surgery, because surgery is a morbid procedure. You cannot be operating on a patient who is severely anemic, for instance. That becomes unsafe, right? So that is safety. So you need to look at her as a holistic, in a holistic manner. Okay. So understand the domain-wise marking: safety, communication, your applied clinical knowledge, information gathering. Structured communication. When you are practicing, what you are trying to achieve is a structured way of putting across things. That's very important. Use timed role play practice. We have already seen this. And focus on patient safety. So your management plan that you make will be under applied clinical knowledge, but that has to conform with the principles of patient safety. Important. So what to do? So there are a few things that you need to understand as far as the MRCOG Part 3 exam goes. You need to know who you are. Okay, you are the ST5 in most of your stations. Yeah, you are the ST5 for that matter. So you are a registrar, you're not a consultant. Important. First thing to note is that you're not a consultant. So when you have to take decisions which are complicated, and if you do not involve consultant, that is going to go against safety. Okay, so understand that you are the registrar. You may be an infertility specialist, otherwise you have a soaring practice, private practice, etc., etc. Doesn't matter. In the exam, you are just a registrar. So you would be talking as though you are the resident doctor and not the consultant. So there are times or there are situations wherein you should say, I would inform the consultant, but do not overdo it. Don't call the consultant for every small thing. That's not right either. All right. So you should know who you are, where you are. For example, there was a task on a structured discussion, twin pregnancy. Okay. And it was mentioned that the patient is admitted to the ward and you are the ST5 and you are about to see her and discuss her management plan. You should be aware that you are already in the ward, patient is already admitted. Don't go back and say, okay, I will admit you now. Wrong. You need to understand where you are, the situation. She is already admitted. Do not tell her that I will admit you. Okay? That's important. In fact, the moment the patient, such patient gets admitted, there are other things that you need to look at, like her thromboprophylaxis, for example. Okay, so such things are important. Who are you talking to? Very important. Whether you're talking to, say, as I was telling you earlier, in a structured discussion, you would be talking to your consultant mostly, and in a simulated patient task, you would be talking to the patient. Now, there are certain twists there. Like sometimes they may tell you that you are about to see the daughter of so and so. You're not seeing the patient, but you're seeing her daughter. So you need to be aware that you are not talking to the patient directly. You are talking to the daughter of the patient. All right. So that this is another thing that often a mistake is made. Okay, you need to know who you're talking to. Another very important example is in a labor ward station. First of all, you are all confused looking at all the 10 rooms in a labor ward prioritization or a labor ward board station. But the labor ward station can come in different forms. It can come as a structured discussion wherein you are going to answer to the examiner, or it can come as a simulated colleague task wherein it is given to you that you are the ST5 and you are about to see your senior midwife who is also posted on the labor ward for that day, for that shift. And you are expected to discuss the management plan for your patients with the senior midwife. So now when you go to the task, you cannot say, hi, I'm so and so, and I'm ready for the structured discussion. No, it is a simulated situation. You need to say, hi, I'm so and so, and I'm ST5 posted on the labor ward. Here you can say ST5 because it's a situation where you're talking to another colleague of yours. Okay, so hi, I'm the ST5. I'm posted on the labor ward. I believe you are the senior midwife, and we could discuss the patient's management plan. That is all. You do not do it like a structured discussion. So it's very important for you to note the domains, the type of the task, and what is expected of you, the task which is written at the bottom of every task, every station. So that's important. Please understand these things, and these are very common mistakes. Okay, you are first of all extremely confused when it comes to a labor ward prioritization. You're anxious when it comes to labor ward prioritization. All you do is read the labor ward rooms and you ignore what is instructed. That should not happen. The first thing that you should do is your instructions. Your instructions would be the question. This is a simulated patient task. The task assesses this, the body of the task. And your task is to, in the next 10 minutes, discuss management plan with the senior midwife. Please do it with the senior midwife as is asked in the task. Do not say, I'm so and so, I'm ready for the structured discussion. That's a common mistake. Okay. Next, urgency of the situation, very important. If you think that there is a lady who is in shock, you cannot be saying, hi, how are you? What do you do? No. You need to understand that she is in shock and you need to say she's bleeding. She may not be in shock because she has to talk to you, etc. Say she's bleeding, she's having PPH. You know, you have to debrief or talk to her about shifting to the theater, something like that. You cannot just go and say, hi, you can just say that I'm the doctor posted on the labor ward and I'm here to help you and support you. I would need to ask you a quick questions. Is that okay with you? Are you comfortable? This is how you would start. because it's urgent. All right. If there is a patient who's come with severe vomiting and she's not able to talk, she's telling you, doctor, I'm feeling sick, etc., etc. Don't say, hi, may I confirm your name? May I confirm your age? What do you do for a living? No. You start by saying, hi, I'm the doctor here. I'm one of the doctors here. I would be addressing your situation. Are you feeling fine right now? Do you want me to get something for you? This is how you're going to start. So again, it depends on the situation, the way you start. All right. So understand situational awareness, the concept of situational awareness very well when it comes to part 3 exam. Okay. So structured discussion. Remember, there are certain things that you need to do when it comes to a structured discussion. First of all, when you're reading your task, when you know this is the task, organize your thought process. Now, in a structured discussion, there are either 4 domains or 3 domains. If there are 4 domains, there is information gathering written there. Most of the candidates skip these 4 domains. I mean, skip reading that. 4 domains means information gathering, communication with colleague, patient safety, applied clinical knowledge. The moment you see that there is information gathering, you know that you would need to be asking history, doing the examination and investigations, because otherwise information gathering would not have been there in the domains, isn't it? Simple logic, right? Sometimes it is not mentioned as a domain which is assessed. It is just mentioned the task assesses you on communication with colleague, patient safety, applied clinical knowledge, just 3 domains. All right. So if it is 3 domains, you know that history, you need not go into the depth of it because there is no marking for information gathering. Okay. Yes, you may need to say that, okay, if it's a, say, for example, placenta previa management, you would need to say things like, I would like to know if she's bleeding, because that tells you about the management, whether you need to manage her now or later. Okay, so that's different. Certain points in history, you know, you need to know for management, that's different. But when you see information gathering as one of the domains, that's when you know that most of the cases, your first question would be, what further information do you need in this case? Isn't it? Most structured discussions start with what further information, particularly when information gathering is there. So when you know that that domain is there, you expect this particular question. Okay. Another very common mistake that is done by most candidates is when they ask what further information you need, the answers given is, this is the history I would like to take. That is it. That's wrong. What further information is not only history, it is history, examination, and investigations. Please note, because all of this is information gathering. Information gathering is not just history. All right, a common mistake made by candidates. So when you say history, you enumerate the points in history, then you move on to examination and say, I would like to examine in the presence of a chaperone with consent because this is a point that goes in safety. You cannot examine a patient alone. You need her consent and you need a chaperone to examine her. Very important point. And you say the investigations that you would do. Okay. And when they ask you what is your further management, please don't just talk about the clinical management that you're going to do. You need to also talk about counseling. What are the points that you would tell her when you're counseling her? Important. You are also going to address clinical governance measures. Like, for example, when there is a patient who is a case of vesicovaginal fistula, you're going to talk about, yes, MDT, and I will do classical repair, I will do a let's go procedure, and all those things. I would involve the urogynecologist, the consultant, IV antibiotics, blah, blah, blah. But at no point you have mentioned, I will counsel the patient regarding her situation, debrief the patient. I would counsel her that she may not, uh, about the complications associated. Okay, for example, say it's not this, say it's a case of high blood pressure in pregnancy. So what are the management? You will say labetalol, you will say magnesium sulfate wherever indicated, you will say investigations, renal function, platelet count, and all that. And you will forget one important point is counseling the patient what can go wrong with her. That's important in management, isn't it? So you say that I would like to counsel the patient that because of high blood pressure, she can have pulmonary edema, she can have abruption, she can have growth problems, On all of these things you can say in medical terms because you're talking to your examiner. But we tend to forget this. So we remember it when we are talking to the patient because that's how we have trained ourselves to start talking to a patient by telling her, okay, these are the risks. This is what we are going to do for you. All right. That is how we usually start. But we forget it in the structured discussion because we are talking to the examiner. So in the structured discussion, your management has to be classified as counseling, clinical management, clinical governance measures. What is clinical governance? Like a case of VVF, you need to talk about incident reporting, DATEX, debrief, duty of candor, feedback to colleague. So all of these things are important. All right, let's look at this. What does a simulated patient task consist of? It starts with your introduction, then you have your agenda that if it's very clear in the task, you don't have to say that long sentence, okay, so I'm going to take your history, I'm going to examine, I'm going to do this and that. No, if it's very clear, just go straight and ask her permission to take history. Okay, otherwise you need to set agenda. All right, and you need to ask history. Examination is not always required, remember that. But if it is going to change your management, then yes. Like if it's a case of preconceptional counseling for, say, sickle cell disease, your examination is not going to change anything because you already know she's sickle cell disease and she's planning a pregnancy. So in this task, you need not say examination. Okay. So only where it is going to change your management, like for example, a case of vulval itch. Okay, even though the report is there, say it's given to you as it's Paget's disease, but here your examination would change the management because you want to know if it's localized to one area or it is generalized. You want to know if there are any lumps or any ulcers on the vulva because that will change your management. You may need to take a biopsy from that region. Okay, so such things you need to say examination, but otherwise not all cases. Most cases you don't need examination. If it is given to you that the GP has examined and it's unremarkable, assume that it's unremarkable, you don't have to examine. Please note this because you're going to waste time unnecessarily saying that I would like to examine you, and then you say a long sentence, most of you. I would like to check your abdomen. I would like to check your internal examination. I would like to check pallor. I would like to take pulse. I would like to take blood pressure. No. First of all, whenever examination is required, just say a simple thing. Is it okay if I examine you in the presence of a chaperone? I may need to check your vulva or something like that, local, a specific thing. If you need an internal examination, say that I would need an internal examination. Is that okay with you? All right. So this is what you need to understand about part 3. Not all the points are essential in all tasks. Okay. So your SPT task will be introduction to agenda, history, management. So how to begin? You first have to understand the task in the 2 minutes time that is provided to you before the station starts. Okay. So I would say just read the task carefully. Do not make notes and everything. You have to just grasp the situation. Okay. So it's important to read and understand this task well rather than just making notes in your notepad in the 2 minutes time. All right. Understand the patient situation and assess the role player mood. It may be given to you sometimes that the role player is angry, or say, for example, the husband is angry and you're about to see the husband of the patient. So you need to be prepared that you're going to face anger. That's important. So how do you start? Hi, I'm Dr. Ankita, one of the doctors here. How may I address you? Okay. So rather than may I confirm your name, may I confirm your age, you can say, how may I address you? Simple. May I confirm your age, please? Then I believe you are here for so and so, or I believe you are here to discuss reports. When there is just notes which are mentioning her condition, you say, I gather from your notes, so and so. Okay. If there is a GP letter or there is a letter from midwife, you would say, I have gone through your GP letter or the letter from midwife, whichever is the case, and I believe you are here to discuss further options. See, sometimes what can happen is the GP may have written a long letter, okay, a long descriptive letter to you. She may have written, say, the patient had a vaginal delivery, following which she had an episode of PPH. After that, patient had pain in the episiotomy. After that, patient had an infection. And then now she's having dyspareunia. And that is why she's here. And that is why I'm sending her to you. If this is what is written in the GP letter. What students do, what candidates typically do is they read everything. I believe your GP has sent you because you had delivered so and so many days ago and you had bleeding and then you had an infection and you're having pain during sex, blah blah blah. No, you don't have time to do all that. All that is already there, documented in the GP letter. You just say, I have gone through your GP letter, I'm aware of your situation. Is it okay if I ask you a couple of questions to know you better regarding this? And then go to an open question. So tell me more about your situation. Simple. Patient will open up to you. All right. These are the tricks that we use to help our students as well in the course. So to not say everything that the GP has to document or GP has told you in the letter. So that's how you start. Okay, if she's come to you on her own, just say, I believe you are here because of period problem. I believe you are here because of pain in the tummy. Is it okay if I ask you a couple of questions to know you better? Okay, and then you go to the questions. Okay, when you start with an open question. That helps always, whenever it is applicable. All right. So open question is when you just ask her to describe her situation. For example, say, can you tell me more about your complaints, or can you tell me what exactly brings you here today? If it's not clear from the notes that is given to you, or it's not clear from the task that is given to you, you just say that, tell me exactly what brings you here today. Okay, so this is how you should be practicing, and this needs practice. It doesn't come automatically, so this needs quite a bit of practice. Special situations. If it's a young girl or a teenager, you could change your tone. You could sound a little friendly. You say, Hi, I'm Dr. Ankita. I'm one of the doctors here who would be helping you today. Okay, something like that. And if it's mentioned, her name is mentioned, say her name is mentioned as Anne. You can just start by saying, I believe you are Anne, isn't it? So then she says yes, and then you can proceed by saying, so what is it that you do? What brings you here today? Okay, how's school, how's studies, you know. Then you also, if it's something which is related to period, something related to gender, or something related to sex or other such issues, or pregnancy, teenage pregnancy, please say, don't worry, everything we discuss here would remain between you and me. Okay, confidentiality. All right. So, and yes, some of you may ask me if it's a case of, say, abuse, sexual abuse, then you have to break confidentiality to safeguard the patient. Then why do you say confidentially? You can even say things like, everything that we discuss here would remain between you and me unless I feel that your safety is at stake. Okay. So basically, you're saying that as long as it's possible for me to keep it confidential, I will keep it confidential. I will only break your confidentiality if I need to keep you safe. That is what you're trying to tell her, in other words. All right. So, such simple things will help you. Okay. Practice them. So, when it comes to subfertility, SRH, particularly when there is a sensitive issue that is being discussed, remember signposting, remember confidentiality. When you are dealing with sexual reproductive module, young girls, or subfertility, because you would need to ask about intimate questions, say in the beginning itself, in the beginning of the task, like say it's possibly say vaginismus task, and almost all your questions are going to be asking her intimate questions or discussing intimate things. So what you need to do is you need to tell her in the beginning of the task that don't worry, whatever we discuss here would remain between you and me. I may need to ask you certain intrusive questions if that's okay with you. All right. So this is how you would begin right in the beginning of the task. Okay. Angry husband. You start by saying, "Hi, am I speaking with the husband of so and so?" Do not just start, even if he's yelling at you. Just say, just be calm and say, "Please, may I confirm if I'm speaking with husband of so and so?" Because it's important to confirm identity. It may be some other patient yelling at you about some other husband yelling at you about some other patient altogether. That should not happen. Okay. Say I'm Dr. XYZ, one of the doctors who would be speaking about your wife. Okay. So this is how you can start. Uh, Cancer, bad news. If the patient is already aware, start with a low voice. It shows empathy. Hi, I'm Dr. Ankita. I'm aware of your situation and sorry we have to meet under such circumstances. So this is the tone. See, I changed my tone as I was talking to you. So this is how you need to do your tasks. Please have this fixed in your mind and please practice in such a manner. So agenda setting. We have covered the initial bit, that is the introduction. So now agenda setting. Okay, so you could avoid it in lengthy stations. Okay, like there is a lot of things described. Don't say that, okay, all this has happened. I would be taking history, I would be examining, and then I would discuss your plan, etc. No, you can just start. Is it okay if I ask you a couple of questions so that we could formulate a management plan together? If she's come for preconception counseling, just say that, is it okay if I ask you a couple of questions to know you better so that we can have a plan for your pregnancy? Simple. Okay. So, and do not say that I would like to examine you in the presence of chaperone, etc., etc. Right in the beginning, because you don't know whether you would actually have to examine her at all. Examining, if you need examination, that would be decided based on your history. So before taking history, do not just simply say, I would like to examine you in the presence of chaperone, just to set the agenda. The agenda is clear that you need to make a plan for her. Okay. You can also say that if there is a patient who's come to you with for discussion of reports, just ask her, is it okay if I ask you a couple of questions and we can discuss your reports later? Don't give her the option. Do you want to discuss the reports first, or is it okay if I ask you questions first? Don't give her the option. You just directly tell her, is it okay if I ask you a couple of questions? And then we could discuss the report with you. If then she says, no, 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 I want to discuss the report now, then that's fine. Then you say, okay, all right, I would be discussing the report now. And then you discuss the report. All right. So respect her wishes if she insists on knowing and having the reports known in the beginning. Now, there are certain tasks where, say, for example, patients come with decreased fetal movements, and patient is anxious because she's not getting good movements of the baby. She's worried. In this case, you cannot just keep on, and you know the ultrasound is there. Ultrasound is showing a heart, fetal heart is there, and you are having concerns about, say, Doppler changes in the ultrasound. For example, it's a small baby, but fetal heart is there. So in such a case, when the mother is anxious in the beginning, uh, it may not be right to tell her, okay, I'll take some, I'll ask you a few questions now, and then we can discuss the report. The mother would say, no, tell me how the baby is. Then don't hesitate to tell her, see, your baby is currently fine. We can see the baby's heartbeat. That much if you tell is fine. She will be relaxed. You can tell her the detailed report later, like you can explain to her the Doppler a little while later. But for her to be calm, she needs to know if the baby is alive, isn't it? It's simple logic. So just tell her that yes, the baby is having a heartbeat. Stay calm. Okay? So then you take the history and then you can tell her about the rest of it. You say that I would be discussing the rest of the report in a few minutes, in a bit. All right? This is important. Okay, so how do you know these things? You need to basically be aware, and you need to anticipate the patient's reaction. Okay, please understand. Most of the times they will tell you in the question itself, patient is anxious as she is not getting good movements. So you would be expecting a question from them. How is my baby? How is my baby, doctor? Please tell me about my baby. Okay, so tell her that the baby is currently doing okay. You need not explain the whole Doppler to her. You explain it after your history, but calm her down by telling her there is a fetal heart. All right, so this is important. Okay, so your history basically will be tell me more about your complaints situation. Okay, assess what she already knows. Background knowledge of the patient is important. Say patient has come to you to discuss Down screening report. Okay, now you have to describe what is Down screening. You have to tell her what is Down syndrome, and you have to tell her what are the options, all those things. How would you know if the patient already knows what is Down syndrome? Right? She's come with a screening report. It is quite likely that somebody previously has explained to her what screening is. If that is already done, you need not explain to her. You're going to waste your time explaining the screening. So ask. Background knowledge. For you to know the patient's background knowledge is important because you can build your task based on what the patient already knows. Important. All right. Then elaborate on the chief complaints, any relevant complaints, obstetric history, menstrual history, medical history, surgeries, allergies, medications, contraceptives, your family history, and this is a mnemonic that we use, SADS and BBB. SADS is basically your smoking, alcohol, drugs, allergies, support, smears, sexual history. BBB is blood group, reservation to blood transfusion, and BMI. All right, so this is something that we always had at the back of our minds whenever we did our simulated patient tasks. Okay, and um, we had to filter the history part. Okay, that's important. You cannot be asking all of these points in all stations, please. Wrong. That would be wrong. That would be considered irrelevant if you ask everything in all tasks. All right, so ask what is relevant, but these are the general points that you may need to ask. Okay, like patient is in the 36th week of a pregnancy. She's come with, say, high blood pressure. And then you ask her, do you have family history of cancer? That is not right. Remember, all of these detailed history is taken at the booking visit. It is not done again later. It's only done at the booking visit. Right? So you need not ask the detailed history every time thereafter. Rest of the antenatal period, you need not ask all of the family history of thrombophilia, family history, or say ethnicity of the patient, any previous contact with chickenpox. All these are booking questions done at the booking visit. Okay, so there in the rest of the antenatal period, you ask what is relevant to your situation. Okay, this is very important for us to understand. All right. At the end of the history, in order to avoid missing any point as such, you can always say, thank you for all that information. Is there anything you would like to add? There is no need to summarize because when you summarize, you're saying the same things that you have already discussed before, that you have already picked up from the patient before. You're saying the same thing all over again. Okay? That is not going to contribute to your score. Remember, this is a tick box exercise at the end of the day. As you are saying the points in the task, the examiner is marking in his answer key. So avoid summarizing, particularly in maternal medicine tasks. There are so many things that the patient has. She's having epilepsy, she's on multiple drugs, she's having a last seizure was so and so months ago. She has not seen her specialist. All of these things you cannot be summarizing at the end because you're going to waste time. It's like repeating the history again. Okay, Instead, thank her for the information. Just ask her, is there anything you would like to add? Okay, because if there is specific concern or there is something that she wants to know and she's not said it in history and you have not asked for it, now is the time that she may reveal it to you. Ask her if there are any specific concerns. Very important, because if she's having a concern, for example, there was a task of sickle cell disease, she's come for pregnancy planning. What is the major concern that she has is whether this disease is going to be transmitted to the baby. And say you know your sickle cell task very well and you have told her everything about sickle cell disease. Okay, what are the screening investigations? How is the management? What are the complications in pregnancy? About aspirin, about low molecular weight heparin, everything you've told her. But you have missed this point about transmission to the baby, and that was a role player question. You did not give her the opportunity to answer because you were too much in a hurry to finish off because you know that this task I have mastered. I know this task very well. So I will say all the points. So you've not given her an opportunity to talk. And the role player question was, how is it going to affect my baby? So you missed it entirely. And when there is a role player question in the script, the examiner key will also have answers to that question, and you have not addressed it. So that's not right. So give her the time, give her the opportunity to express her concerns. Management. Whenever applicable, do not forget MDT. That's a very important safety point. Do not forget to say multidisciplinary team whenever that is applicable, but don't say in all situations. It's not applicable everywhere. Okay, maternal medicine tasks, yes, MDT. Onco, yes, MDT. Urogyne, not MDT. MDT is not always there, but when you are considering surgery, when you're considering invasive procedure, yes, MDT. Okay, referral to a specialist. These are safety points that I've enumerated. Referral to a specialist whenever applicable, like fetal medicine center. Down screening positive. Do not forget the most important point there, that you have to refer her to a fetal medicine center for an invasive test or NIPT, etc., etc. Omission of drugs or addition of drugs. Omission of drugs like HRT when there is a clot, DVT. Oral contraceptive pills when the patient is having DVT. Addition, addition of aspirin in cases where it is indicated for women with pregnancy. Okay, your blood thinners, your low molecular weight heparin, wherever applicable. So addition, omission of drugs is important for patient safety. Address the risk factors that have been identified in history. If you do not, you will lose in patient safety. And this is very, very common. There is a patient who has BMI 35. She has come to you with atypical endometrial hyperplasia and she wants fertility preservation. You talk about everything. You talk about putting an LNG. You talk about following her up with serial endometrial biopsies every 3 months, etc. And once everything is normal, everything is fine, then you talk about fertility options. You talk about the option of removing the uterus and then maybe surrogacy also as an alternative. All of that is done, but you have not addressed the BMI. The BMI is the major risk factor that has contributed to her having atypical endometrial hyperplasia. And if you do not address the BMI, you will fail in safety. Fail in safety. I'm not saying you will fail the task, but in safety, definitely you will fail. And that's something that will go against you in the circuit overall. Please remember that. Okay. So always address what you have picked in the history. For example, in the case of uh, use overactivity, patient has been smoking, and you talk about everything else. You talk about bladder training, bladder diary, urine routine, you talk about intravesical botulinum, etc., etc., and you forget to address smoking. You're going to lose on safety straight away. More so because, again, Know who you are. We've discussed this before. You are the ST5, and it's your job. You're the registrar. You're not the urogynecologist. It's your job to advise lifestyle measures, to do the basic prep for the patient so that she can be then seen by your urogynecologist. So that this basic prep is addressing risk factors. All right. So if you miss that as an ST5, that becomes a blunder. If you don't know how to manage what dose of botulinum is used, for example, for OAB, that's not your fault because you are the ST5. You're not the urogynecologist who's going to do it. Okay. So you need to address the basics. Do not forget PIL. Very important. Okay. It's very important to mention that a patient information leaflet. Red flags. Okay. Whenever you're telling a patient about VIN, for example, your vulval intraepithelial neoplasia, you need to tell them that they need to see you as soon as you she notices that there is a lump, she notices there is an ulcer. Okay, these are red flags. Or you have done a procedure, say on the cervix, like a LEDS procedure, and you have discharged her. It's a red flag if she has fever in the post-op period, if she has foul smelling discharge. So you need to make her aware. If you don't, that's against safety. So all of these are important points in safety. Please note. Follow-up plan again is in safety. Contraceptive advice again very important. Preconception counseling will be a task typically where the patient is unfit for pregnancy. Okay, she may be on some drug. She may be having a condition that makes pregnancy contraindicated. In that case, you cannot say, okay, go ahead, have folic acid. We will connect you with the specialist. We will have MDT. We will see you in consultant-led unit. No, you need to optimize her condition before the pregnancy. So you need to make sure that she doesn't get pregnant now. How do you make it sure? By telling her that she needs to be on a contraceptive method. That's safety. Other methods, other points which are important, support, counseling, very important. Okay, support counseling is important. Documentation, consultant referral, discuss, appointment, or these are important points. And write back to GP or midwife if they are referred from GP or midwife. Let's look at modules. Early pregnancy. Wherever applicable, don't forget BBN. How do you do BBN? This is very important. How do you do breaking bad news? Always. A bad news should be started by giving a warning shot. Okay? You cannot be breaking the news directly. You need to give them preemptively a warning shot. Okay? So you need to first ask her, are you alone today? As I would be giving you a lot of information. Okay, a lot of candidates do this. They will ask, are you alone today? Because I have some concerning news. The moment you say that there is some concerning news, the patient knows that there is some concerning news and the purpose of breaking bad news is defeated. So what you need to do is you ask, are you alone today? As I would be giving you a lot of information. Don't yet say that there is concerning news. You say it later. Okay. The next step, I have your reports with me and I have confirmed that this is your report with your name and your NHS number. This is confirming that the report that you have actually belongs to the patient. Again, it goes in favor of in safety. Okay. So confirm that it is her report with her name and her NHS number. Then say, I have some concerning news for you. So first you have made her comfortable by asking if there's somebody with her. Then you say that I have confirmed that this is your report with your name and NHS number. And then say that I have some concerning news for you. Okay. After that, you can say that if it depends on how bad the news is, something like cancer, something like IUFD, these are the worst news, right? IUFD, don't just say that your baby is dead. You need to tell her that yes, you did have decreased fetal movements, and that is why we did a scan. And I'm really sorry to be saying this. On the scan, it appears that your baby hasn't been moving, right? First thing, don't say that the baby has died. Your baby hasn't been moving. We checked the baby's heart and we couldn't find a heartbeat. I'm really sorry, but your baby has died in the womb. This is how you need to do your breaking bad news about IUFD, for instance. All right. If it is a bad news, but it is not that bad a news, you can maybe use one warning shot. Say, for example, in this case, ectopic pregnancy, early pregnancy module, ectopic pregnancy. So you can ask her. She comes to you with some um, lower abdominal pain, and you've done a scan and you've checked that it's an ectopic pregnancy, etc. So you say that you can start by drawing. This is your womb, this is your tube. Normally, the pregnancy is implanted in the womb, and that is where the pregnancy grows. However, in your situation, the pregnancy is implanted in the tube. And I'm really sorry to be saying this. This pregnancy cannot grow further. This is not an ongoing pregnancy, and this is something that we refer to as an ectopic pregnancy. We need to treat it. Okay, so this is how. So the warning shot is not. Um, it's a single warning shot. It's not an extremely. Yes, it is a bad news for somebody who is trying to conceive hard. Maybe yes, but depends on the scenario. All right. So this is what you need to do. Then red flags are also important whenever there's pain, bleeding, giddiness, etc. that you need to warn her about. Do not forget to say RPL clinic in case of RPL. Folic acid when she's in early pregnancy. Do not forget to say that. Booking investigations when she's in early pregnancy. In case of failed pregnancy and molar pregnancy, tell her that she needs to be on contraception, okay, before she tries for the next pregnancy. If she has a miscarriage or an ectopic pregnancy or molar pregnancy, support PIL. These are important points. Subfertility, empathy, because these women are trying and they are depressed that they are not getting pregnant. So empathy is important. Smears, STI screening, support, signposting before sensitive issues, investigations that are done already, options of surrogacy and adoption wherever applicable. This is something that we don't offer. Okay, like the one that I discussed, the atypical endometrial hyperplasia. See, the treatment for atypical endometrial hyperplasia usually is hysterectomy, right? And you are giving her the option of LNG IUS, which is the second best option, okay, because she wants to conceive. But for a woman who is concerned about her health or who should be concerned about her health, you can always tell her that there is the best option or the first option that we usually offer is hysterectomy in this case. And if that is the option that you choose, then for fertility, you have the option of surrogacy and adoption. So these options should not be forgotten. Okay. Do not forget referral to fertility center, consultant, etc. whenever that is needed. Confidentiality, signposting are very important. We have already discussed this before in subfertility module. Child welfare issues are important while deciding funding. For example, there is a lady who's been a smoker, who is say 42 years old, and she's a divorced single basically, and she wants a baby. So here, child welfare issues becomes important. If she asks you about funding, you can always say that I will write to the clinical commissioning group, and they will let you know about this because not all IVF cycles are funded on the NHS. Got it? In antenatal care, I have highlighted these three drugs because in antenatal patients, you don't prescribe drugs just like that. These are the drugs that are given, that is aspirin, low molecular weight heparin, folic acid. But if you forget these, that's going to go against safety. Like if you forget aspirin in a case where there is previous preeclampsia, you forget aspirin in chronic hypertension, you forget aspirin in APLA, that's going to be a blunder. You forget low molecular weight heparin in cases where there are risk factors for thrombosis, that's a blunder. So these three things is any antenatal patient that you have. think of these three drugs, whether they are applicable. Okay, and maybe folic acid and vitamin D can be also included in this. Screening, down screening, diabetes screening if applicable, SGA screening if applicable. If applicable, say those things because diabetes is not applicable in all patients. At least down screening is offered to everyone. Diabetes is not. But if you find that there are risk factors for diabetes, you need to say that I would offer you screening between 24 to 28 weeks. If there are risk factors for SGA, you say that I would offer you screening. Do not miss these things. Consultant level follow-up if there is high risk, which typically your stations would have. Delivery in obstetric unit. These are important points in antenatal care. Maternal medicine, always stick to the template. We have a maternal medicine template, right? Wherein we ask the history, we introduce, we can set the agenda depending on what it is, preconceptional or antenatal care. Take the history, say effects of disease in pregnancy and vice versa, effects of pregnancy on disease in one sentence. Don't mix management with effects of disease in pregnancy. For example, there is a risk of high blood pressure. Say, for example, she's come with sickle cell disease in pregnancy. You're going to tell her about the risk of preeclampsia. Okay. What students usually do is they say, okay, because of sickle cell disease, there is a chance that you may have high blood pressure later in the pregnancy, because of which, and growth problems, because of which we will start aspirin. What is happening here? You're saying the effects, at the same time, you're saying aspirin. You're mixing management with effects. In the bargain, what can happen is this. You may miss out on one or two points in important points in the effects of disease on pregnancy. And management, you may miss out because you have not organized your management. You're saying things and then you're saying the management. Okay. So say the effects because of sickle cell disease, there is an increased risk of miscarriage, growth problems, clot formation, hypertension, high blood pressure, and so on and so forth in the pregnancy. Because how the pregnancy can affect the disease. The anemia may worsen, there may be more sickling crisis, more requirement for having admissions, etc., etc. Then say, you would be managed a multidisciplinary team with a hematologist, a consultant-led care. You would be offered aspirin, you would be offered screening for urinary tract infections and thromboprophylaxis. Blood thinners may be offered, more frequent visits. This is how it should be. Okay, so effects of the disease in pregnancy, vice versa, management. Management would be antenatal, intrapartum, postnatal. Do not forget intrapartum and postnatal. At least say that the delivery should be in an obstetric unit. Okay, so another important thing, when you have a patient who has a medical disease and she's come to you because she's anxious in the pregnancy, to not just start by saying, okay, because of the issue, because of the epilepsy, you can have all these problems. First, say that most women in her situation are likely to have a straightforward pregnancy. However, these are the problems. That's important. Okay, so first give her a reassuring statement and then say, but these are the common problems. Do not forget MDT, okay, in maternal medicine tasks. Referral, review of medication. She may be taking teratogenic medications. You need to review those. Again, aspirin, low molecular weight, folic acid, vitamin D, important. EIL, consultant-led care, obstetric unit delivery. Labor and delivery. In the history, your history should be limited to a certain things. Obstetric history, medical history, surgeries, about the pregnancy history, basically. Support. Allergies is very important, even if she's in labor. And the three Bs. Do not ask when the patient is in labor, do you smoke? Do you drink alcohol? Do you do drugs? She's in labor. Please understand the situation. Okay. What is going to affect your management in labor is what you're going to ask. What is going to affect her management? Whether she's having a medical problem, whether any previous surgeries like a previous cesarean. What is her pregnancy history been? Whether she has someone with her right now, whether she has any allergies to drugs. These are the things that will affect your management labor. So ask only those. Okay. If she wants to have, say, home delivery, it's a negotiation task. Patient wants to have a home delivery and she has multiple comorbidities, and she says she has twin pregnancy. So, firstly, ask why she wants home delivery. What is her idea? What are her thoughts? What does she know? Important. Because she may be having her own thought process, her own ideas, which you need to address to convince her that her home delivery option is not good for her. Okay? Explain the modes of delivery and the associated risks. In negotiation tasks, do not forget to say the worst possible outcome for the mother or the baby. Okay? Like she wants to have a home delivery for twins. The problem with home delivery is that maybe twin one may deliver easily, twin two may get stuck. Okay? And if that happens, or there is cord prolapse or something like that for twin two, and if we do not do an immediate cesarean in that case, the twin can die. And that is important for her to understand. She thinks that, okay, if that happens, I can come to the hospital and then have my delivery done at the hospital. So you need to tell her we do not have that much time if that happens. The baby may die in seconds. That's something that you need to tell her. Okay, so tell her the worst possible outcome. Otherwise, she will not be informed. And when she's taking her decision, it will not be an informed decision. That's important. Okay, in advanced labor, second stage, do not say PIL because they cannot read there in second stage or in advanced labor. In gynecology, there may be hidden agenda like high BMI, as I was discussing, herbal medicines which are estrogenic that she may be on. She may be desirous of fertility. You may need to treat, or you would need to treat rather, other associated problems like anemia, as I discussed earlier, fibroid uterus, anemia, and she's for fertility. Please don't forget that you need to treat that anemia. So you need to buy time for building her hemoglobin. You need to give her medicines that is going to stop her bleeding for now, right? And then, and maybe contraceptives, and then treat her for the anemia, and then consider surgery, that is myomectomy. Okay, so that's important. Um, you need to have situation specific treatment for her. Okay, so not everything under the sun would be applicable to all the patients. So if it's a fibroid uterus, specific to her situation, don't say expectant management when there is heavy bleeding. No. How this is affecting her quality of life is important for you to know. Fertility wish is very important. Empathy, support, counseling, PIL, these are important points. Onco. Ask whether the patient already knows the diagnosis. Empathy. Breaking bad news is very important, again, just like IUFD. And another important mistake made by students. A lot of students say that there is a cyst in the ovary, there are suspicious features, and I'm afraid it appears to be sinister. That's it. Sinister is said. Patient is supposed to interpret that sinister means cancer? No. You need to tell her that it could be cancer. You need to use the word cancer. If you hold it back, then it implies that you have not given her the full information that she has the right to know. Okay? So don't say vague English terms. These are English terminologies. Sinister is an English terminology. It doesn't mean cancer. For a patient, it is something serious. So what is it? Is the patient asking you? And you keep on telling, no, there are changes which are sinister. This is something that happens almost every mock exam that we take, almost every class or session that we take with a new batch of students. They just say that there is sinister pathology and that's it. And the patient is supposed to interpret that. Never happens that way. Okay, so please tell her that this cancer. MDT is important, definitely. Relevant investigations. Do not forget tumor markers, CT scan, PIL, documentation. Sexual and reproductive health. Again, as earlier discussed, sensitive information. So signposting, confidentiality, safeguarding, rape cases, etc. STI screening, and safe contraceptive advice. In a young girl with suspected abuse, confidentiality, consent, capacity, contraception. These are the four C's that you need to evaluate. Post-surgical risk factors for any surgery that is proposed to her has to be discussed with her. Steps have to be mentioned. Consent taking is important. Tell her the alternate options whenever there is consent taking. Ask whether she knows what are the alternate options. Otherwise, it again becomes uninformed consent, not informed consent. Remember the pillars of consent taking: voluntary, informed, and she has to be mentally competent. You cannot just take a consent from a patient who has Alzheimer's. Okay. In a consent taking task, please make sure that you get it signed from the role player. You have to pretend that you're writing in the consent form, and you need to push the consent form to the role player and ask her to sign. You can scribble on the consent form. You cannot have the time to write everything that you're seeing in the consent. So you write a few things as you are talking. Don't separately write it there. As you are talking, write in the consent form like her name, her hospital number, etc., etc. And then you forward the form to the patient to sign. Okay, and also another important point in core surgical is principles of enhanced recovery. Important. Post-op is usually you have post-op complications. So you need to check the relevant care bundles, the remember ABC of resuscitation, and relevant points like IV line, oxygen, antibiotics, nil per oral, like in case of bowel injury, in case of sepsis. Always remember sepsis can be a possible differential. So antibiotics, IV line, oxygen, nil per oral, imaging, these are common scenarios post-op. Okay, bowel injury, ureter injury, these are common things, or intraperitoneal bleeding. For all of them, IV line, oxygen, antibiotics, the relevant care bundle, ABC of resuscitation, do not forget. Postnatal, we remember it in the with this mnemonic A B C D E F. ABCD is in immediate post. A is analgesics, antibiotics, anticoagulants whenever indicated. B is breastfeeding. C is contraception. D is documentation, DVT, prophylaxis, DATX. Very important. Discuss, debrief. E is expert opinion. Like she has a problem, medical disease. You say that I would like to refer to an expert. Okay, like she needs a follow-up appointment with an expert. That is uh, your epilepsy specialist, uh, your hematologist. So it depends on who the expert is. So do not forget that. And the follow-up plan. Okay, so all of this is important. In teaching, okay, in teaching, make sure that you have a friendly attitude, building rapport. So start by saying, "Hi, I'm Ankita, and you are, and how have you been doing in the department? Are you happy?" And you can even make out from her attitude if she's happy, she's being bullied, etc. So if you do have any issues at any point, please feel free to seek help. So I believe you want to learn about forceps. Why have you read or seen? Okay, that's background knowledge. Okay, important in a teaching task. The agenda in a teaching task is set by the colleague. Please understand. Now, for example, it's a task which is expecting you to teach forceps to your colleague. Forceps is a topic that can be covered in 10 minutes as well as an hour. How do you know what to say? You would know what to say only if you ask your colleague. Okay, so ask your colleague, that is the role player, what is it about forceps that you want to know? That gives you the agenda for the task. Always in a teaching task. And this is a common mistake which is done by most candidates despite telling repeatedly. Okay, ask your colleague to repeat, then appreciate. I can see that you are a fast learner. Am I clear? Important. Okay, to check understanding, important. Give her resources, give her feedback, and no, ask for feedback on your session and say that I could show you next time how this is done. So things like that. It's important. All right. You can even ask her to repeat things that you have already said. Don't put a new question to the colleague. Please remember they are not MBBS students or your gynec students. they are sometimes they are not connected with your topic. So don't put a new question and they will go, I don't know. Okay, then what are you going to do? So you ask the colleague to just repeat what you just said. All right? Urogyne? Urogyne, please remember that these are lengthy uh, tasks. Okay? So now what are the things that you need to do in Urogyne? History is important because most of these tasks are incontinence tasks. Okay, so most of the time, or sometimes a lump in the vagina with incontinence, prolapse with incontinence, for example. When there is incontinence, do not forget to rule out the other type of incontinence. Like if there is urge incontinence, do not forget to check if there is stress incontinence along with urge incontinence. Ask whether she needs to rush to the loo. Does she leak while she is rushing to the loo? How often does she visit the loo? Frequency. Does she wake at night? Nocturia. Has she noticed blood in urine? Is there pain while peeing? Is there pain in the lower tummy? Is there weight loss? Because it can suggest something like cancer of the bladder, etc. Sexual history. How is it affecting her sexual life? Social. Smears. PMI, chronic cough, constipation. Important because these are the things that you should address before going to the definitive management. Coffee intake, etc. Fluid intake. Occupation, because she may be a lifter, a weight lifter, and she is having a prolapse. So you need to tell her that that may aggravate the prolapse. She could, or may not discontinue, but she may pay more attention to her pelvic floor health. Quality of life, mental health, interpretation of urodynamics is important. Okay. Do not forget to say urine routine. Again, a typical mistake. Urine routine, which is the most basic investigation, is forgotten. Do not forget bladder diary wherever applicable. It's a pure incontinence, stress urinary incontinence. If you miss bladder diary, is fine. But if it's a mixed incontinence, you miss bladder diary is not fine. If it's a OAB, you miss bladder diary is not fine because bladder diary will help you know how much fluid she's taking that you need to regulate in OAB. For that matter, any sort of incontinence, have a bladder diary. And lifestyle modification is very important in urogyne. Please make a note of that. All right, so with that, I think we have covered the salient features. Of course, there is a lot to do and lot to say and lot to learn in each of these modules, but we have covered the salient features and how to go about your tasks in the various modules. You can ask me questions now. If there are any questions, please don't hesitate to ask. You can even put it in a chat box or you can message on the group as well. Up to you. No questions? Can I assume that everything is understood, whatever we've discussed today? No questions? Yes. Dr. Rosa, Dr. Tasneem, Dr. Fatin, Dr. Atif, Dr. Kalmini. If there are no questions, I think we'll wind up. Thank you so much. Also, please let us know what if there is any specific task you would like to discuss because we plan on having more such sessions. Today was just an orientation session, but we plan on discussing tasks, etc. So please do let us know. And please give us feedback on our Excel Part 3 group as well on the Telegram.